move on to objective 3. Analyze the needs of the client across the lifespan during the pre, intra, and post-op phases of the surgical experience, and we're going to think safety, infection control, those kinds of things. So here again, this is taking us through the different perioperative stages, the pre, intra-op, and post-op. And what I did was I just kind of separated them out, thinking about safety issues and things that maybe we might want to consider during those 3 stages. Okay? So with the preoperative area, we've already talked about something that we'd want to consider there as infection control. You remember we talked about the skip measures and how we give the antibiotic within an hour of the cut and discontinue it 24 hours after the end time of the surgery. Talk about the catheter, getting it out early so we don't get UTIs from that. You follow where we're going with that? Okay. So those were kind of things that we planned up front in the preoperative area, but it carries us all the way through. And when we're thinking about safety as it relates to the preoperative area, the first thing we have to think about is we have to do good patient identification, right? And you all know what we use as 2 patient identifiers. If you don't know by now, we're in trouble. What are they?
Name, date of birth.
Name, date of birth. Can't use a bed number or a room number or anything like that. And we also want to make sure that we identify allergies, you know, things like that for our patient. We want to make sure that we are checking safety-wise that informed consent is signed, okay? We're going to talk about the role of the nurse in one of the other objectives as it relates to the informed consent. We'll do that later. Okay, we talked about how important it was for the nurse to look at that pre-surgical checklist. That's a safety thing, making sure everything's done that needs to be done. Okay, I want to tell you a couple of things there that comes to my mind is that when you're doing a pre-surgical checklist, you know, there's things that you have to go down the line and you have to see that's been done.
Maybe out there.
Oh yeah, I did let her go, didn't I?
Yeah.
Girl, you took too long.
Lo siento.
I did let her go, but I didn't know she wasn't back. Okay. All right. Ain't gonna do no more.
No more.
No more. No more. Okay. Y'all, I just want to say this right now about going in and out of class. All right, nothing personal, guys. It's nothing personal, but we got to be consistent with what we do. All right? And the thing here is there's a ruling now that if you leave the classroom during class, you don't come back to the break. I don't know if y'all been told that or not, but that's what it is. And the other thing is I did give her permission at the last second to go, but she took a little too long.
All right. Won't happen again.
All right, good. All right, as long as we all on the same page. Nothing personal. Okay. The pre-surgical checklist, things that you got to think about. That's so important when it comes to safety and when it comes to infection control. Because, first of all, what happens in that area determines whether or not they go forward with this surgical procedure, right? Tell me some things that you think that would need to be done before they could move forward into the OR. Other than, we talked about informed consent and identifying your patient.
They had all their pre-op testing done?
Okay, y'all hit the nail on the head pretty good. All right, so you're talking about NPO. All right, first of all, y'all understand why a person has to be NPO, right?
Mm-hmm.
Why? Exactly, so they don't aspirate, right? And so these folks have a certain period of time that they have to be NPO. So if they come in that day of surgery or whatever and tell you they drank something earlier that day, you know what I'm saying? That may shut that thing down. You see what I'm saying? And on that checklist, it's going to say how long they've been NPO. Because they'll ask you, how long has it been since you've had something to eat or drink? Well, it's just been about an hour. Well, You know, we probably can't go there right now, okay? Y'all follow what I'm saying? So NTO status is very important, okay? And you talked about having any
Pre-op testing.
pre-op testing. What would be a pre-op test that you'd have done?
EKG, vital.
Okay, there you go. So they're gonna look on that pre-surgical checklist and they're gonna say, okay, yeah, they've had their EKG done, they've had their labs done. So what happens, just knowing that they had these labs done and this EKG done, is that satisfactory? How can we take that a step further as a nurse?
To look at it, like to have results.
That's correct. You need to know that those results are there. And it's the responsibility of the nurse to look at those results. You know, and if there's something that needs to be called attention to the OR team, they need to not wait on that. You see what I'm saying? Because what would happen if a person had a high potassium?
They need to fix it before they have surgery.
Exactly. You don't want to send a patient to surgery with a 6 potassium, okay? Or with a 120 sodium. You know what I'm saying? Let me tell y'all something. And I know I've told all other folks that I've taught in the past. The best thing, and I don't know if y'all have this or you don't have this, but I'm going to give you a little advice, and that would be to make yourself a lab sheet, to where it will tell you what the normal lab values are. So you can know those lab values, because I promise you on these tests, you're going to have lab questions. And if you can't pick out a normal lab value or an abnormal lab value, you're going to miss that question. You see what I'm saying? And that's going to happen all through your program on every content. But with this part right here, yes, you've got to assess those labs, okay? And those labs need to be done early on. They don't need to wait till right before the surgery's fixing to happen. So it's our responsibility, if there was an order put in for labs, then it's our responsibility as a nurse to make sure that gets done early on, so we don't not have the information for that person. Because they come in the day of surgery now. Y'all realize that? They don't always have a day or two to get this stuff done. Sometimes they come in that morning, they get this stuff done, and we have to see what the priority is as to what needs to be done first, second, third. Okay? But y'all did good. You hit on the NPO, you hit on the assessment of all of their pre-tests and things, if it's been done, and if the results have been forwarded on to the healthcare provider. That's important. And that's all on the pre-surgical checklist, and that keeps us honest so that we know we've covered everything and done what we need to do. All right, and then they document clearly things like what does the patient say they're having done, okay? And I know I've probably told y'all this before, some of you maybe not. When I had my cataract surgery, when I went in, they asked me which eye I was going to have done, and I told them my right eye, so they put my armband on my right arm. When I was put in to the back to have the surgery, they again asked me which eye you having done. I told them the right. So they put one of those blue hats on me, and they put a tissue right here over the right eye. And so, of course, they asked again when they started to put the numbing stuff in there. But when the doctor came in, the doctor said, okay, which eye are we going to do? And so I said the right. And so there went a big X above that right eye. And it does say in there that the patient and the physician are supposed to mark it together. Okay? Not necessarily that the patient has to reach up there and make that X, but you're communicating at the time that that's done. So it's important for us as nurses in the pre-op area and doing that time out and all of that to make sure everybody's on the same page and that we don't cut off the wrong leg or operate on the wrong eye, whatever the case may be. Y'all understand that, right? Okay. All right. I'm going to back up just a minute on these labs because I just want to make sure that everybody's okay with labs. What kind of labs do you think we might need for a surgery? Okay. Okay. All right. So basically, a lot of them. Okay. What would we be most interested in a CBC? What? Okay. Okay. Huh? Okay. Okay, plate. A lot of it. You see what I'm talking about? There's a lot of things in these. Huh?
Everything.
Everything? Okay. Because, yeah, we're going to be interested in whether they're going to clot properly, right? Or maybe they too clotted. Okay, already. And we want to know whether or not they got enough blood, or they might need some blood. You know, if they have a low H&H, they might not have the surgery. You know, who knows? And then the next thing would be, like we talked about with the potassium and the sodium, that could be out of whack and they may not have the surgery. They could have some sort of UTI or something. You see what I'm saying? I just want to make sure you understand the significance of the labs, because that's part of pre-op, and that's a real important part of that. Okay. The other thing I put down here is that we have to make sure that these people, when they sign their consent form, they haven't been given any drugs. See, they got to be alert, oriented with themselves, you know. We can't go in there and get them to sign something after we've given them a preoperative medication of some sort to calm them down, okay? We got to make sure if we do give those drugs, we put the side rails up. That's safety, all right? And we also make sure that they have, like we talked about earlier, if they're going to have a certain surgical procedure, that that site has been cleaned properly. You know, we tell them a lot of times they have instructions that they're going to have to do a body wash of some sort before they come, right? And then when they get there, we may have to prep that site, like shaving, you know, with a electric razor or whatever. And a lot of times, what other kind of preps might they have before they come in? What would be another type?
Cleanse.
What kind of cleanse?
Yeah.
Okay, what's the purpose of that? What's the purpose of having
So
a
they
back,
can see.
an enema? Like
Everything that's going on. Make sure they're not constipated.
a bowel surgery of some sort?
Maybe like an abdominal surgery, just
Yeah.
in case, I don't know.
Okay, but what's that gonna do if they do an enema and cleanse this person's bowel? What's the purpose of that?
Decrease the
For
risk
them
of
to
infection.
speak, better for them to speak.
Okay.
And cut down any chance of actually having issues that can go for infection.
Okay, for infection. See, that's what we're talking about here on this objective. We're talking about preventing infection, right? Talking about safety, right? Okay. So that's a good example, you know, of that. So you got to think like that. What's safe for this person? What's going to prevent infection? And what's the role of the preoperative nurse as it relates to that? Okay. So the next thing we're going to talk about is the intra-op, safety, infection control in the intraoperative period. Okay, what was that? That was something. Okay. The checklist, the person that's in the intraoperative area, they're going to have that checklist as well, and they're going to have things that they have to assess. Things that they look at as far as risk assessments and things like that. And making sure that that consent form was signed. Everything's as it should be. They're going to highlight any kind of allergies that this person might have, so they're aware of that. They have that time out with everybody that's involved in that procedure, so they make sure that they're doing, you know, the surgery appropriately and on the right body part. Okay, they also in the intraoperative thing, a safety infection control thing would be what they're wearing. And this is where they all have to make sure they have on the proper attire for them. If they're around that sterile field, they have to be in all sterile stuff, right? Okay, everybody understands that. And if it's the anesthesiologist or the anesthetist in the back over here, they're not right up there in there. Neither is that circulator. All right? So y'all understand about the different attire and making sure that it's proper for their role. And, you know, we talked about earlier about how everybody's responsible for watching for that break in sterility. And that's one of the things that's a safety issue plus an infection control issue in the OR. Yeah, we talked about marking the site and all of that. That's important. And that's when the person first comes into the OR, and that's done a lot of times with the timeout. Sometimes they'll do it with their timeout. But the physician and the patient has to participate in that, if possible. Okay, so they will check for any kind of discrepancies during this time. And this is the time where a safety thing would be putting on those grounding pads. Do y'all understand what that is? The grounding pad? Those are the things that would protect the patient from having an electrical issue if they would get shocked, you know, as a result of the equipment that was used on that table. So they use what we call grounding pads. All right, they may have to continue to clean the skin, prep the skin, whatever, you know, not necessarily shave the skin like they were talking about, but they would go and do their skin preparation more thoroughly before the surgery in order to prevent, excuse me, any kind of infection. And what else do you think in the OR they might do that would prevent an infection or be a safety issue that I hadn't mentioned? Y'all awake? What does the circulator and the scrub nurse do together?
They count
What are they counting?
every piece of material, every piece of
Okay.
supply.
So is that a safety issue?
Yes.
Yes, it is. Because that has to be done. And of course, you know, it has to be documented once it's done, but that's a safety issue. I'm repetitious on a lot of this, but that's what these objectives do, is they kind of bring you back around so you understand how all this works together. All right, the post-op area. Let's talk about safety and infection control there. Okay, in the post-operative area, you know, these folks are just coming out of anesthesia, right? And so what kind of safety issue might you think of when they're moving from the OR to the recovery room? Okay, we're talking airway, right? We're talking vital signs, you know. You've got to look for any kind of change in that patient's condition at all and continuously monitor them, okay? Now, if, let's just say they had a dressing on, what is an infection control issue there as it relates to dressings that a person comes from the OR with?
Make sure it's intact.
Okay, make sure it's intact.
Make sure you use sterling and changing it.
That's correct. That's right. So you're going to have to use that good aseptic technique when you're changing a dressing on a person to prevent an infection, right? Because you can't just go in there and just haphazardly change a dressing. You got to use good aseptic technique in order to prevent an infection. Y'all, this is not rocket science, and I know that you think it's very simple. But you know, when a person loses their life as a result of somebody not using good aseptic technique because they didn't change a dressing properly, that's serious. You know what I'm saying? You know, it's easy for us to say these things, but the reality of it is that you do have to make sure that you use good aseptic technique on all dressing changes, you know, to make sure that you don't contaminate and cause an infection. Okay. In the OR or going home or on the same day surgery, whatever, there's certain criteria that they have set in place that has to be followed in order for people to be able to go home or be discharged to another unit, okay? And that's a safety, that everybody follow that protocol in order to, you know, let them leave the OR let them leave the recovery room and go to home or either go to the surgical floor. So that's a safety thing. As far as the equipment, all right, you know, we talked about safety in the OR with faulty things and making sure we had grounding pads and things like that for safety. When you get to the recovery room, what kind of equipment do you think is a safety issue there that you might would need? Suction?
Mm-hmm.
Huh?
O2 and amber bag?
Yes. You're gonna have to have some way, airway management if you need it. Yeah, and a lot of times they're connected to monitors, right? For the blood pressures and the heart rate and so forth. But as they move forward to the floor, you know, you have to have the proper equipment out there. So all of these things are important, you know, and that's safety. And also, we have to consider infection control when we're using any kind of equipment. All right, so I think that probably covers all of that as far as the 3 stages and the infection control and safety issues. And we already talked earlier about how when we move from one place to the other, who's responsible for making sure, you know, that you have that good handoff report. And regardless of where they're going, there needs to be a good handoff report. And that in itself is a safety, right? Because they have to be told things that happen to them and things they need. So that's a safety. All right, Objective 4. Objective 4 talks about integrating knowledge of actions, contraindications, potential side effects, and nursing implications of medicine as they relate to things like also the complementary therapies or alternative type therapies. And it speaks to infusion pumps here and using them in the plan of care for the patient. So let's talk about this for just a minute. You've got a PowerPoint, like I say, that relates to these medications that you're going to be responsible for. And I think the main thing you need to take from there, you know, is read over those and make yourself just familiar with them. So if you had a question on something, like for instance, and I'll go over that in a few minutes. I'll look at the PowerPoint. If we have time, I'll run over that with y'all. Okay? But for right now, let's move through our objectives and I'll come back to that. All right, but I want to talk to you on this objective about the alternative therapies and the complementary type therapies. So what do y'all think you could do is, you know, when it speaks to that, what is an alternative or a complementary type therapy? As it relates to medications. Like a person's in pain.
And what is it called, imagery?
Guided imagery. Yeah. Okay, to me, I think that's more of a diversion. You know what I'm saying? All right, what can you divert people's attention with? You know what I'm saying? TV? Is that guided imagery? You know what I'm saying? That's what I'm thinking. I'm not going to hold up a flower and say, you know, guided imagery, you know, but I think more or less in terms of maybe if they had a visitor, somebody, you know, that could talk to them for a little while, get their mind off of their pain or whatever's going on with them, okay, till their pain med kicks in. But positioning. I'm going to tell y'all something. I've been a nurse for 40-something years, okay? Matter of fact, 44 years this year. So I've been around the block and back, okay? And one of the things I learned in my basics when I came to this program back in 1975 when I graduated, and one of the things that I still remember, and I still do in my nursing care, is I give back rubs. I don't even know if y'all talk that anymore. Okay? But I'm going to tell you something. In my whole career, there's been very few things that have been consistent. Things change all the time. Basic care don't change much. Okay? But when I thought of this objective here, that's one of the things that I thought about and I put here was giving the patient a good massage or back rub that's appropriate. Okay? Because there's a lot of times when they lay on their back in these beds and they get all these wrinkles from these sheets on their skin, okay? It's nice, if they can, to turn them over, use some of that lotion that sometimes comes with them in that room, and give them a back rub. Now, y'all know what? Y'all remember that, movie, what was it? Mr. Miyagi, you know, does, what was that?
Karate Kid.
Karate Kid, you know, that massage. You know what I'm saying? We were taught like that, to do back rubs, okay? And I'm telling you, these folks appreciate that, and I could put them to sleep at night, because I had to work at night, and I didn't want to, be up all night. So, you could do good back rubs, and really, it does, it helps people. Hey, y'all go home and get somebody to give you a back rub. That's your take home from today, okay? All right, and like I say, if you reposition these folks, if you take and, give them a little back rub, that might help them out a little bit. All right, that's my talk on complementary alternative. The other thing that was in this objective here had to do with the PCA pump. All right, who's used a PCA pump or seen them? Some of you seen them, some ain't? Okay, all right. Y'all know what that is, right? It's that pain, that's pain control, anesthesia stuff, okay? All right, I mean, I can give you a personal example of that one too. Many years ago, I had one, and what they're doing is they're designed to deliver just a small amount of pain medication when you feel like you're fixing to hurt, which is the way to do it,
Stay ahead of it.
Exactly, and that'll help you out. Well, anyway, I had surgery, and I was trying to wake up, and every time I'd try to wake up, I'd be knocked back out. And I couldn't figure out why I couldn't wake up, and I was getting nauseous from just all that medication. And so, when I started waking up the next time, I had enough sense to know not to open both eyes, so I could figure out why I couldn't wake up. Well, my husband was over here punching that button constantly. He had me knocked out. And once I realized what was happening, I just pretended that I was awake, And I didn't say anything. I pretended I was asleep, I'm sorry. And I was awake. But anyway, I'm just telling you that these are great, but, at some point, you have to quit punching. You know what I mean? So, that's just a lesson, because I'm telling you, as nurses, you know what I'm saying? You may go in there and find out your patient ain't waking up, and you wonder why they're not waking up. And it could be somebody in there's punching in buttons. But that's what you have to do. You have to teach your patients PCA is for them. And you have to tell the family,
Not to touch it.
don't be fooling with their stuff. It's for them to punch. Okay?
Was he just trying to keep you knocked out?
Knocked out. He was watching Indiana Jones. Whenever I woke up, there was that big ball rolling across. You know what I'm saying? I'll never forget that, because that made an impression. And that was a long time ago.
My
All
favorite
right,
movie.
well, just keep in mind that, pain medication is not designed to knock you out and keep you knocked out, nor is it designed to get rid of all the pain, because it can't, but it can help to minimize the pain and help you get through, what's going on. All right, objective 5 has to do with providing preoperative discharge and home environment education. All right, so how are we going, in the preoperative area, discharge starts on admission, right? Y'all heard that all the way through. Okay, so when we're talking about people who have had surgery, and we have done a lot of that pre-op education. What we talked about in level 2, how important it was to go ahead and educate these people before they had the surgery, so that whenever they had the surgery, they understood why they had these SCDs on. They understood, why they might get these injections to thin their blood a little bit, why they need to use that incentive spirometry, and why they might, something else, turn, cough, deep breathing, why early ambulation is so important. why they need to splint when they cough. Y'all know where I'm going with all that. Okay, so a lot of that pre-op education is important in getting them ready to go home. So you do that up front before they even have the surgery, and it makes it easier on the backside. And then, of course, when they do go home, you want to give them written instructions. You know, just like my issue with the midazolam or the Vitiated. You know, they may not remember everything you say. So it's always good for them to have written instructions. And that they need somebody to drive them home, whether they're in the hospital or having the same day surgery, whatever the case may be. And a lot of these folks, prior to them going home, you've got to assess what they might need at home. Do a good assessment, and that's what this environment education's talking about here. You know, what do we have patients go, what do we do for them before they go home sometimes in an effort to help them when they go home?
Set up home health,
Set up home health. What else might they need?
like assistive devices at home.
That's correct. What kind of assistive devices might a person need when they go home?
Walker, a potty chair.
Okay, all kinds of things. Any type of equipment that they may need to be able to help them and make it easier for them to recover and have better outcomes. Okay, a lot of people, the two other things that I think about that's important, because I worked home health some years, and I remember, you know, having to take care of some of these folks when they come home from the hospital and they didn't have everything they need. You know, you got to think about things like, do they have somebody that's going to cook for them? How are they going to get their food? Is somebody going to prepare those meals? They're going to get Meal on Wheels or Daily Bread or whatever they have nowadays, you know, that will help them to have food prepared. You can't, y'all, sometimes people just go home by themselves. They don't have anybody to help them. They don't have nothing to eat, and they just had a knee surgery, but they got to go upstairs to get to their house. You know what I'm saying? So that's the environment I'm talking about. And I tell you, a lot of times until you work home health, you don't realize the challenges that a lot of these folks have when they go home. You know, in the hospital a lot of times, we focus so much on just making sure they get out of the hospital alive. You know what I'm saying? That we don't think about what they have, the challenges they have when they go home. You may need to make doctor's appointments for them. Make sure they have a transportation to go and come. So you may have to get caseworkers or social workers involved. That's what this objective is talking to y'all about, okay? That's the purpose of that, making sure they have what they need when they go home. Objective 6, certain priority actions for clients undergoing surgery. As nurses, you have to set priorities. You always have priority questions, right? Okay. Do y'all know how to take a priority question?
That's debatable.
They're all correct.
Okay. They're all correct.
Correct. You gotta
at
find the
some
best
point.
correct one.
What's,
Right.
what's gonna kill them first?
But which one's gonna kill him first? Yeah.
Who's gonna drive?
Okay. What's gonna kill them first or what's gonna save them best? Okay. All right, but it's a priority, and what I like to do with the priority is I look at all 4 of them. Okay? And I'll say, okay, what do you do first? What's the most important thing that you do?
Assess.
Okay. You're gonna assess to know what you gotta do second, right? Okay. But safety, airway, all of those kinds of things are important. All right? But you've got to look at, you know, when your 4 choices are there, you're going to say, okay, I'm going to do this first, this second, this third, this fourth. Okay? You can't do them all at once. You know what I'm saying? So when you're looking at those things, you determine what's the most important thing you need to do first. And then what's second, and what's third, and what's fourth. And see if that works. If it don't work, you might want to rearrange them. You know what I'm saying? But you got to be able to set priorities. And every one of our objectives on every content that you're going to have has to do with setting priorities for your patients. So that's, as far as for priorities for patients undergoing surgery, we could stay here all day and talk about that. But I just limited to the fact that you're gonna look for safety, airway, assessment, those kinds of things. All right, objective 7, analyze the nurse's role in obtaining informed consent. All right, y'all know what the nurse's role is?
Yeah.
All right, tell us.
Just a witness.
Witness
Witness the doctor,
the doctor.
giving them all the information they need and answer all the questions they have, and making sure it's
Make
signed.
sure they understand.
Okay, so what you're telling me is that the physician is responsible for giving the instructions to the patient about the procedure, the risks, the benefits, and so forth.
Yes.
And they're going to give that instruction, and we're going to witness that patient's signature. Is that correct?
Yes.
All right. Now, you know, in level 2, we talked about that, you know, we have to make sure that if a person cannot see and they make an X, you have to have 2 signatures by 2 nurses, right? And same way, if they don't hear well or they have some kind of issue as to why 2 people have to sign with an X because they can't write or whatever. The other thing is if you have an emergency situation, if y'all remember, and you had a person that came in unconscious and needed surgery, and you couldn't find a family member to sign, or they couldn't sign, then what was the option?
2 doctors, right?
Not affiliated.
That's right, you'll have 2 healthcare providers, and I'm reiterating, oh, thank you. I'm reiterating a lot of this because the students that are transitioning in didn't hear some of this stuff. Get that back there. You got 2 physicians unrelated to the case that can agree that this person needs to have this surgical procedure, and then they can have it done. Okay? It has to be 2 unrelated physicians. Okay. But y'all just remember, the main role of the nurse is to witness that person's signature. Not to instruct them in what's going on or the procedure at all, but if there is an issue, and y'all know this too, if that patient has questions about that procedure after they've signed it, and you have signed it, but they come back later and say, well, I didn't quite understand what he said about this, what you gonna do? Get them back in there, right? Get the doctor back in there. You know, we can maybe clarify a word or some little something like that, but we can't give the instructions, okay? And we have to be very careful about trying to get in there and put words in the physician's mouth, clarifying. See what I'm saying? So the best thing to do would be to call that physician back in because they've got a question about it now. All right. Objective 8. See, we're moving along pretty good on these objectives. The first one's a little slow. All right, objective 8 says intervene to provide a safe environment for the surgical client. How are we as nurses going to make sure that our patients stay safe? A lot we've already talked about, right? Okay. Tell me something in general, like a general thing that you could do that would help keep your, or at least your patient will know you're trying to keep them safe.
Bed rails.
Okay, good bed rails is a good way to keep them safe, at least not falling out of the bed. Okay. Huh?
Identify that they're the right patient.
All the patient identifiers. How you gonna know it's the right patient?
Assessment. Cause I'm
Okay.
gonna have the patient I'm supposed to have and make sure that's who's in bed.
Okay. All right, we talked about the 2 patient identifiers, right?
Mm-hmm.
Okay, assessment. Okay, one of the things, when you're assessing a patient, you know, first of all, when they come in, I mean, you're assessing all the way through, right? You're assessing all the way through. And doing that good assessment is gonna let you know if there's an issue there that could cause a safety issue for that patient, all right? Let's think of something. what would be something that if you were doing an assessment, you would see that would cause you to be concerned with safety?
Bruising, especially if it's at different colorations,
What is that?
if they're at different levels of color. Because if they have like some that are more purplish and some that are yellow, that's a sign of neglect or abuse.
Oh, okay, all right. And you know, there again, you know, when patients come in, doing a good assessment, we have to look at them all over, right? We can't just, you know, we look at the whole body, right? We take pictures nowadays, right? Okay. And one of the things that does, though, is that protects us, too. All right? Because if you're doing an assessment, you see something that looks suspicious and you take pictures, they can't say we did it. You know what I'm saying? So that's something y'all need to kind of keep in mind, too. But always remember, though, that you're a patient advocate. You are taking care of that patient and being their eyes and their ears and their voice when they're not able to be that or do it for themselves. And when these folks are unconscious in an operating room on a table, okay, somebody has to be their advocate and keep them safe, is what I'm saying. And if they have advanced directives, we're supposed to honor those advanced directives. All right? So that to me is where we could intervene. You know, they don't want this. They have an advanced directive, you know. So that's just an example that I came up with. And you always want to address any questions that they may have, you know, and if you can't answer them, you go find somebody or, you know, something that can. And another safety thing, I think, in the environment issue, and we've talked about it before, is equipment. Faulty equipment. You know, there could be issues with having something that's shooting out fire. Who knows? You know what I'm saying? Or you might just see a cord that has a little break in it that would need to be replaced. Okay. I'm going to do a little somewhat review with you. Then we're going to kind of go over those meds and I'm done. Okay? All right. I want you to really focus, like I told you, on looking at labs. Say y'all are in level 3 now. And I think you need to really know your labs. So that, you know, if you see a question that has to do with labs, you'd be able to pick out whether or not this one's normal, this one's normal, this one's not. You just need to know that. And a lot of this, when we talked about the labs earlier, we talked about how a person can have issues with electrolytes in surgery or before surgery. They can have like that calcium that could go up with that malignant hyperthermia, okay? You could have an issue with the potassium. You could have an issue with H&H. You could have an issue with kidney issues. When people go to surgery, you know, they may have kidney issues already that needs to be identified. They may have problems with their liver. Who knows? You see what I'm saying? So y'all just need to make sure that you really have your head wrapped around lab values. We talked about, I guess one of the things I want to make mention is doing assessment. She mentioned a while ago about an assessment. You know, it's important for us to think about when we're taking care of people and we assess them, what puts people at a greater risk for infection or a safety issue? What will put them at a greater risk just coming in for surgery?
They're smokers.
Right off the bat. Huh?
They're smokers.
Smokers. What else? Compromised immunity. What else? Oh, yeah. That's probably a problem.
Hypertension, COPD.
Right, that's right. Hypertension, all of these, diabetes. You see what I'm saying? Y'all need to think like that here. Is because if you've got patients who come in automatically, if, just like I say, you're gonna look at their labs and you're gonna determine whether or not they've got an infection based on their WBCs, or whether they got a low H in H, or whether their potassium or sodium or whatever's off. You're gonna learn that, okay, from the labs. But as you progress on with this content or any content, remember that as people age, comes problems. Anyone that's 65 or older has more of a risk or a potential for a safety issue. Y'all know what I mean? They could fall easier, or something could happen to them. They could be like she's talked about, immunocompromised just because of their age. That could cause some issues with safety or infection control. All right? I'm just trying to remember those kinds of things. So think age, over 65, think labs, think whether they were a smoker, any of these things that might cause them to have a greater risk for infection. Any of these comorbidities, as they call it, like diabetes, things like that. All right, because people with diabetes don't heal as well. That's why I'm saying that. Y'all understand that, right?
Mm-hmm.
Okay, because the glucose kind of destroys some of the white blood cells that fights infection, and so therefore that person is slower to heal. Okay, there's a reason for that. Let me think if there's anything else that I want to talk to you about. We talked about the importance, and we hadn't talked about the meds very thoroughly, and I want to get y'all out of here at 11:15. I want to give you time to get a break, and ones of you that need to go before you go retake a test or whatever you got to do. Let me think of what else I might want to talk to you about. Okay, we didn't talk a lot about like post-op drains and things like that, because to me that's an infection control issue too. Because if a person has a drain, and they come out of surgery and they have this drainage, and we did talk about doing aseptic technique though with dressing changes. Okay, but what do you look for when you do a dressing change? You look at their skin, and what else are we looking for? Okay, what are we looking for with the drainage?
Color, odor, consistency, and
There you go.
appearance.
That's your coca stuff, right? You're looking for that. You're looking for the amount. You're looking to make sure, like if they have a drain specifically, like a Penrose drain, you know what I'm saying? You'll see how much drainage is coming out because how often the dressings are being changed. But what if you have one of those, what do they call them, Hemovacs or J-Vacs or something like that? That's in a container, right? Okay. What would indicate to you that that person was getting better? Less drainage, right? So if you're seeing that they had more drainage, then that might be an indication of something else going on, right? Okay. I just kind of want you to think like that, okay? Think about those kinds of things. I think you will. Number one thing we need to, let's don't ever forget, the number one thing that's going to keep people from getting an infection from you is what?
Hand washing.
Hand washing. Hand washing. Don't ever forget that, guys. It's always and will always be the most important thing is hand washing. Okay? All right, I'm going to go over the, I think I have a copy. I'm not positive I have the right PowerPoint for these meetings, but I'll go for it. We'll see. Any questions up to this point? Anything that you know of? I did my best to cover the objectives the way I kind of felt like they should be covered. That don't mean that's how you gonna cover them. But, I want to make sure y'all covered the objectives. I'm sorry. you tested on the objectives, the content on the objectives, and you need to, at least be familiar with it. Okay? All right, now I'm gonna just run over these labs for the next 5-10 minutes, and we're done. Y'all don't have any questions? See, I wrote all that stuff in my book so I could keep us honest and keep us on track, and wouldn't wander off out here in that rabbit hole, and this one, you know what I mean? That helps me, hopefully help you. Okay, so on this, I'm not sure if this is y'all's or not, to be honest with you. Has agonist opioids on it. Y'all familiar? Okay, well y'all know what opioids are. You've had that before. These pain medications that are given. We've talked about the PCA. You know, we've talked about that as part of anesthesia. Could be a preoperative medication, could be an intraoperative or post-op medication. Okay, what do we know about opioids? What do they do as a side effect?
A respiratory depressant.
Absolutely. Respiratory. What's a normal respiration?
12 to 20.
What is it?
12
Give me a
to 20.
range.
12 to 20.
12 to 20. 12 to 20. Everybody agree with that? All right, good. You need to know that. What's a normal respiration? Okay? Because, you know, 4 is not normal. 12's okay. All right? But the lower it gets, the worse they're getting. Right? Everybody's good with that. All right. What else do we know about these opioids? What might be another little side effect they might? Huh?
Hypotension.
Okay.
Constipation.
And constipation. That's right. It's all right here somewhere in this thing. Okay. Huh? Yes, right. Level of consciousness. All right, but let's talk about this constipation a minute, because we always think of that with surgery. You know, whenever they put the bowel to sleep, because everything's been put to sleep for a while, and it takes a minute for that to wake back up, right? So it's going to take a day or two for them things to come back around. Okay, but what's priority? Is priority your respirations or your bowels? Just check. Just check. Okay. All right. Now that blood pressure might be dropping a little bit. Okay. It might be. What's priority? Okay. All right. Now, they might even be getting a little bit dizzy from it, or, you know, like you said, maybe be a little bit loony. You know, they might not be able to add 1 and 1 or something. But there again, they're still breathing, right? Okay. So I just want y'all to put that in perspective. As far as the next list of drugs you have on here is your agonist antagonist. And these, you know, sometimes we see those used. What is it? Nubane, Stadol. That's generic names. Here it's buprenorphine, now bufene and butaphenol, whatever. I'm not good with these generics, I'll be honest with you. But basically what this is it's got one part, you know, that's going to help with the pain, and one that's going to not so much. It's going to kind of counteract it so it's not too much of a sedative. It kind of balances itself out. Does that kind of make sense? Mm-hmm. One does one thing, one does another, meets together and does a good thing, so it doesn't sedate them as much. Okay. All right. Let me see if I'm on the right page. All right. Okay, we've already talked about, on here it talks about, you know, we can give meds different routes. Mostly you're going to give it IV. We had the PCA pump we talked about. Some people take it TO. And it talks about here about teaching the patient to call for the pain meds before the pain becomes too severe, and think patient safety. And patient safety as it relates to filling those side rails up, you know, monitoring that patient, making sure that they stay safe. All right, then you have, on here, it speaks to us about the opioid antagonist, which is, the naloxone, which is the Narcan. And y'all know the important thing about that one is that if these folks have to have some of the naloxone to reverse that pain medication because they're not breathing but 4 times a minute, what's gonna happen to them whenever?
They're gonna be in pain.
They're gonna be in pain, absolutely. When they wake up, they're gonna be in pain. So we
That's gonna be
need,
fast too.
yeah, and we need to recognize that. All right, and then it goes on to talk about some side effects from that on here, like their pulse will go back up, blood pressure go back up. Y'all know how all that works, okay? They may even get nauseated, vomiting, and perspire. Okay, the next one has to do with anticholinergics, which we talk about atropine here. And what is the purpose of atropine as it relates to surgery? Drive those secretions, right, so that they don't have all that to deal with and they're not going to be aspirating that into their windpipe. Okay, the next one has to do with antihistamines. And what do we give those antihistamines for, such as Tagamet, well, cimetidine, the Deans, for the acids in the stomach to prevent stress ulcers, okay? So that's why this one's on here, and that's what we call H2 blockers, and it cuts down on those stomach juices. All right, then the other medications that's listed, is this the same one y'all have? Well, good. All right, as far as the sedatives here, we have like hydroxyzine, lorazepam, metoclopramide. All right, you've got sedatives, hypnotics, and then you've got the dopamine antagonist. Now, that, which is Reglan, the metoclopramide, what is the purpose of that one?
Metoclopramide, that's for nausea.
Okay, but what does it do to help prevent nausea, and what's it gonna help us to do in the surgical arena?
Isn't it also Anavar?
No.
Oh, that's my cousin.
Okay, let me tell y'all the difference, all right? When you're talking the cimetidine and all the Deans and the H2 blockers,
For H2.
okay, those are gonna cut down on that stomach juice so that there's not all that acid building up because of the stress of actually having the surgery, okay? So that's cutting down on those stomach acids, the juices. But when you're looking at giving them this metoclopramide, which is Reglan, the purpose of that is to get what's in the stomach moved on out, okay? So it's causing that food to go from the stomach quicker into the small intestine. And so it's a rapid emptying of the stomach, I should say, all right? And that's used a lot of times in people who have gastroparesis that have, where they have nerve problems in their stomach from diabetes. And they will give them this medication to help them get their stomach to empty faster because those nerves are not working like they used to. So that's just free information right there on diabetes. So now y'all know that. Okay. That's all I got, guys.
Thank you.